My name is Zoher Ghogawala. It's a great pleasure to speak at the CSRS 2020 virtual meeting. The topic for this talk is prospective multi-center studies. What can we collect and what can we conclude? In terms of disclosure, I will mention some data from the CSMS trial, which was funded with federal grants. Separately, I have intellectual property and shares in a commercial entity called Nidus, which has nothing to do with this presentation. I'd like to acknowledge a number of collaborators: Alyssa Dunbar, Fred Barker, Bob Hury, Dan Resnick, and Bill Butler, all of whom have collaborated on studies with me and helped form some of my thoughts on the collection of data from prospective studies, randomized controlled trials, and registries. I'd like to start with a case. This is a 55-year-old dean of a law school in Boston, pictured here, who is an active tennis player, has had 3 months of tingling in his right hand, recent falls on the tennis court, and felt zingers in both arms in the dentist's office. On examination, he had pathological hyperreflexia, bilateral Hoffman signs, and full strength. And his sagittal T2 weighted MRI is shown here, which demonstrates stenosis at the C4, C5 level and at the C5, C6 level. The patient, being a highly educated patient in Boston with access to multiple hospitals, sought 4 opinions and received the following recommendations. Surgeon 1 recommended a laminoplasty. Surgeon 2 recommended a front back ACDF and C3 to C7 laminectomy and fusion. Surgeon number 3 recommended a laminectomy alone. And surgeon number 4 recommended a 2-level ACD&F at the C4, C5, and C5, C6 levels. This is not uncommon, and we know this happens all the time in spinal surgery. But this was particularly perplexing to this patient who consented to have his story told. He underwent an ACD&F at the C4, C5, and C5, C6 level and did well. He was back playing tennis within a few weeks of his operation and returned to work doing his academic work at the law school. The question, though, as cervical spine specialists and surgeons is, was this the best operation? Does anybody know? And does it matter? And so that allows us to take a look at the current literature. I start with comparative effectiveness, prospective, non-randomized studies, of which the AO studies stand as the dominant contributors in the arena of cervical spondylotic myelopathy. In these studies, multiple centers, both in North America as well as internationally, came together to prospectively evaluate outcomes from cervical spine surgery, comparing anterior and posterior approaches. Some of the major findings from these studies were that surgery for CSM is effective, and even mild cervical spondylotic myelopathy benefits. And this was detailed nicely in a couple of publications, one by Michael Failings in 2013 and a subsequent publication later in 2019. The other thing that emerged from these studies was that ventral and dorsal surgery appears to have different complication rates, with a 12% overall complication rate for ventral surgery and an 18% complication rate for dorsal surgery. The populations were not entirely comparable, with more levels of surgery done in the dorsal cohort, and this represents, therefore, level 2 evidence. But these were findings that could be concluded with a high degree of certainty from a prospective, non-randomized comparison. In terms of background and rationale, as we think about our various modalities for generating new data, we all recognize that in spine there are few randomized controlled trials that are performed. Crossover has often limited their utility, and prospective studies are expensive and difficult to complete. Nevertheless, randomized controlled trials remain the gold standard in medicine, primarily because they eliminate the chance of bias from selection of patients for one procedure versus another. And so I think that as we think about this problem, we know that we have randomized control studies, which still to date represent our gold standard for generating new evidence in our field. But increasingly, we are relying upon prospective, non-randomized comparative effectiveness studies to generate new data in our field, as we saw in the very nicely done AO studies. And we are moving also now into the arena of registries, which is the collection of data in a prospective way that then allows retrospective review of large numbers of patients previously not possible to collect in prospective studies. As we look at the history of randomized controlled trials in spine care, I think one cannot ignore the importance of the SPORT trials in lumbar spine surgery. These trials were aimed to compare non-operative surgery to surgery. And for lumbar discectomy, for lumbar stenosis, and lumbar spondylolisthesis, the results were quite definitive that surgery was superior to non-operative treatment. This was made possible by comparison of patients that were randomized. However, when you look more deeply at the SPORT trials, the crossover rates of 40%, primarily from those patients assigned to non-operative treatment by randomization who had severe symptoms, crossed over to the surgical side. And so ultimately, these trials, while they were randomized, were evaluated as treated prospective comparative trials. And that's what allowed ultimately the comparison of non-operative to operative treatment to occur. Not perfect in the sense that they were not truly randomized comparisons, but it was high quality prospective data that collected patient-reported outcomes data in a reliable fashion with a population that was well-defined and well understood, that allowed still meaningful comparison of non-randomized patient cohorts to generate conclusions. And these studies, as you know, were published in JAMA and in the New England Journal of Medicine, which represent journals that publish our highest level of evidence. We've had significant experience with randomized controlled trials in the cervical spine with the FDA arthroplasty trials. About 8 randomized controlled trials published in this area comparing anterior cervical discectomy and fusion with cervical arthroplasty. And now there are papers with 10-year outcomes data available. Very powerful, and these randomized controlled studies probably represent some of the highest level research in all of spine surgery. What these studies have generated as a collective is that the arthroplasty patient outcomes are superior over time, and there have been fewer secondary procedures in patients treated with arthroplasty. Very, very dramatic contributions to our field that were made possible by doing randomized controlled studies where the patients that were placed in either the arthroplasty cohort or the fusion cohort were comparable in terms of all of their baseline measurable characteristics, as well as things that are not necessarily measured, such as surgeon preference for one procedure versus the other. We have looked in our group at how we can define equipoise in such a way that we can do randomized controlled studies in patient populations which have traditionally been hard to randomize. And we demonstrated this phenomenon by using an equipoise panel where multiple surgeons reviewed each case eligible for a randomized controlled trial, in this case a lumbar spondylolisthesis trial, and found that when patients had an expert review and had greater than half of the people reviewing their case say that there was clinical equipoise, that this patient was eligible for randomization, that the patient was more likely to consent to randomization. As we did this in our cervical spine work on cervical myelopathy, we also provided the patient with information if the vast majority of the spinal expert panel preferred a particular approach, namely ventral fusion, dorsal fusion, or laminoplasty, and those patients were therefore not randomized. And so we designed a trial for cervical myelopathy, looking at comparisons between multi-level ACD&F, posterior laminectomy and fusion, and laminoplasty, comparing ventral versus dorsal approaches. What were we measuring? We were measuring patient-reported outcomes, we were measuring opioid usage, and we were also looking at radiology assessments for the development of fusion or for the lack of complete decompression at the area operated upon. From an employer perspective, we measured productivity, return to work. From the hospitals and from the payers' perspective, we looked at health costs primarily by looking at health resource utilization. Cost effectiveness is an area that is often not included in many of our studies, but is increasingly of great importance as we look at how to steward the limited resources available to us for healthcare. Hospital charges are included in most studies with focus on implant costs, length of stay, and ICU utilization and stay. A future state looks more, I think, at durability of our surgeries, so that we look at the comparison of secondary need for operation, postoperative health resource utilization, looking at radiology usage, looking at physical therapy usage, and also, and importantly, looking at opioid utilization. In this particular study, we designed it as a randomized controlled study. Our primary outcome was a patient-reported outcome, the SF-36 Physical Component Summary Score, looking for a one-year change in minimally clinically important difference of 5 points. We included secondary outcomes, SF-36, NDI, EQ-5D, and the modified JOA measured at 3, 6, and 12 months. And we also looked at complications, productivity, return to work, health resource utilization, physical therapy, radiology usage, and opioid utilization. I'd like to just share some of the results of the randomized study to illustrate some of the things that we can detect when comparing our surgical procedures when randomization is used to equalize the baseline characteristics of our patients. And I show you here these baseline characteristics in 3 groups: ventral surgery, laminectomy and fusion surgery, and laminoplasty, showing that the age, gender, the baseline SF-36 physical component summary score, mental component summary score, modified JOA, EQ-5D, NDI, and levels of stenosis are comparable among the 3 groups. We were able to look at 1 and 2 year change in our SF-36 physical component summary score, and we saw that our laminoplasty patients had a superior and increased change and improvement in their SF-36 score at 6 months, 1 year, and 2 years after surgery compared to ventral fusion and dorsal fusion strategies. We also were able to look at complications, and we noted that the laminoplasty patients had fewer complications, 10% complications versus 27.5% for dorsal fusion and 42.4% for ventral fusion. Overall, there was no significant difference in major complications as we refined our look at these complications, and we noted that many of the minor complications in the ventral fusion cohort were minor dysphagia problems, which resolved within 3 months. We were able to look at productivity and noted that the patients treated with the dorsal fusion were slower to return to work, and that overall laminoplasty patients returned to work sooner than the patients treated with either ventral or dorsal fusion surgery. Looking at health resource utilization, we were able to quantify this carefully after the surgical procedure was done. Diagnostic testing was different amongst these 3 strategies, and we saw that the use of postoperative x-rays was less amongst those treated with dorsal laminoplasty, as well as less ongoing physical therapy at 1 year for dorsal laminoplasty, as well as less opioid utilization for patients treated with laminoplasty. So we were able to make some conclusions, again, by generating through randomization comparative patient cohorts that while ventral and dorsal surgery showed no difference, the as treated non-randomized analysis of patients treated with laminoplasty showed fewer complications in this cohort, less outpatient health resource utilization at 1 year, and superior health-related quality of life scores at 2 years. So just to summarize some of the major points here, registries and administrative data, I think, are most useful for comparing costs and comparing complication rates amongst surgical procedures. These are less likely to be influenced by some of the biases that can come into play when looking at comparative studies, such as patient preference, surgeon preference for a particular procedure, or differences in anatomical considerations that direct either surgeon or patient towards one procedure versus the other. Prospective multi-center studies are very effective for looking at overall effectiveness of procedures, as we saw from the AO studies. They're also very useful at looking at complication rates by refining the study cohort a little bit more than, say, registries do, where there is a inclusion of the vast majority, if not all, patients treated with a particular condition. However, randomized controlled studies, I think, remain as the gold standard for the evaluation of cost effectiveness, where both cost and outcomes assessment are important, comparative health resource utilization comparisons, and comparative outcomes and effectiveness comparisons. Thank you very much for the opportunity to present this talk at the CSRS meeting.